Nice turnout for an important subject. Uh, All right, I'm going to get us started. For those of you that don't know me, I'm Steve Zylstra. I'm President and CEO of the Arizona Technology Council. We're a statewide organization with offices in Phoenix and Tucson. We do public policy advocacy at the local, state, and federal level. We're sort of the voice and the face of the tech industry. We do around 100 events a year. We have all kinds of publications, newsletter to podcasts. We do reports on the tech industry, and importantly, we negotiate lower cost products and services for our members. We run an association health plan. We run a 401k program. We have tuition discounts, by the way, at ASU, U of A, University of Maryland, and soon GCU. So full service trade association serving science and technology based enterprises. I want to welcome you all to our virtual tech speaker series. The topic today is building scalable, responsible AI programs for healthcare. As I mentioned, we do about 100 events a year. I want to mention a few upcoming events. Our biggest event of the year is coming up on November 12th. It's the Governor's Celebration of Innovation. It's one of the biggest tech events in Arizona. It'll be at the Chateau Lux in Phoenix. And on December 3, we have our Cybersecurity Breakfast Forum, again here in Phoenix at GCU. And then in January, on the 14th through the 16th, we have Arizona Photonics Days, again in Tucson. So if you could all place your system on mute throughout the process. If you have questions, please put them in chat. And as we get toward the end, if you want to speak, please raise your hand and our moderator will call upon you. The University of Advancing Technology is our presenting sponsor for the virtual tech speaker series. Typically, we'll have someone from there that speaks a little bit about UAT, but an extraordinary private university here in Arizona. It's been around for almost 40 years. And I like to say it's a university for geeks. With that, I'm going to introduce our moderator. So many of you know her. Minnie Kernax is the technology leader with over 20 years of experience delivering advanced analytics, AI, and digital transformation initiatives across government and global enterprise environments. As co-founder of Mercurio Analytics, she enables organizations to modernize operations, adopt emerging technologies, and shape secure, scalable ecosystems that improve efficiency, maximize ROI, and deliver measurable results. And most importantly, to me at least, she's the chair of our AI committee. So with that, I'm going to turn it over to Minky to introduce our panelists.
Thank you, Steve. Yeah, I think I need to just shorten that to I love helping organizations figure it out. So, so we'll get to our panelists in 1 second. I just want to set up the entire conversation. So today, what we're going to do is talk about AI in healthcare, and it's no longer a question of if we're using it in healthcare. It's more about how we're using it securely and responsibly and ethically to remain focused on the best outcomes in patient care and experience. And the opportunities are extraordinary, from improving diagnoses, predicting risk, personalizing care, but also so are the stakes. Every advancement raises new questions about trust, accountability, and patient impact. And each of our panelists today represents a unique part of that ecosystem, from clinical systems and research institutions to public health and community care. And what we're going to explore today is how governance is moving from theory into practice, meaning how do we define ownership? How do we balance innovation with oversight and build confidence in technologies that are evolving faster than our policies. The goal for today's conversation is not to debate if AI actually belongs in healthcare. Again, it's to understand how we can ensure that it's implemented thoughtfully, compliantly, and securely to serve patients, providers, and the communities safely and equitably. And before we get started with the panelists, I just want to share something that I've always taken for granted. And a lot of times, when we start talking about terminology and technical terms, we forget sometimes that people are not up to date. So, panelists, please jump in if you think if you can add to this. But what we're going to be talking about today is LLMs, agents, and agentic AI. And so, if what I'd like you to think about is an LLM knows the knowledge and can explain, but doesn't act alone. So, if you think about how that would apply in healthcare, that would be like a medical student. An agent can take actions using protocols, tools, and different things. So that would be like a resident physician. And then agentic AI would be the multiple residents, nurses, specialists, doctors coordinating autonomously to deliver continuous care. And that would be like the hospital system. I think I got that correct. Would you all agree? Is that a fair? Yeah. Okay. Good. So let's start by getting to know each one of our panelists. I'd like to have you take a few minutes to introduce yourselves and your role in advancing AI governance in your organization. So, Meg, let's start with you.
Well, thank you. And first, I think I'd just like to mention how honored I am to be a part of this panel. More importantly, making sure that these conversations are taking place in our environment. So I'm Meg Wilson. I serve as the Vice President of Technology and Business Enablement here at Team Select Home Care. So, we are a provider. We specialize in high acuity in-home nursing care for medically fragile children and adults. I think that we are a nice example of, amongst a lot of healthcare spaces where there are far more patients, patient needs, community needs than what we can actually service for. So, as we have approached conversations around AI, it's not for us just a tool. For us, it feels like a lifeline, right? We're like very outnumbered in the things that the community requires, and so using this is one of the most critical things that we can bring this to light to. But of course, with this conversation becomes a really important discussion on how responsible we are for this community. This is our most vulnerable population. So yeah, excited to talk on it today.
Wonderful. Katie, you're the next one on my screen.
Well, I echo what Meg said. Thank you for inviting me here today, and really grateful to have a chance to speak with this group of wonderful individuals and talented individuals. I'm Katie Adams. I'm an administrator at Mayo Clinic here in Arizona. I support several of our clinical practices, but at the enterprise level, I'm also on our generative AI program team. So overseeing the tools that we are developing in-house for use in-house and also externally, because ideally we're democratizing this information and knowledge and not hoarding it or selling it. So I'm really excited to have this conversation because initially I think we're seeing a lot of it, of the advancement helping us with the burden of administrative tasks, but it has such great potential to go far beyond that in the right hands, used in the right way. So this is a wonderful conversation to be having. Thank you.
Awesome. And Nassim?
Hello, everyone. I am like everyone else. I'm really glad to be part of this esteemed panel of all women speakers. I love to see when this happens. And I'm Nassim Eftekhari, Chief AI and Analytics Officer at City of Hope. City of Hope is a NCI designated comprehensive cancer center. We are one of the largest cancer treatment and research centers in the US. So we have 5 hospitals across the nation, including one in Phoenix, and we have 38 community centers, as well as a genomics testing company in Arizona, TGen, as well as a grad school and a very strong research arm that we have called Beckman Research Institute, the first in the nation of its kind. So we kind of, as you may imagine, we are in a really good position to be utilizing advanced technologies, AI. I've been doing this at City of Hope for 9 years. So our AI journey started way before the ChatGPT boom and all of the hype around AI. As we speak, we have AI models, machine learning models that are monitoring our patients in the hospital, fully integrated with our workflows for more than 6 years. So we have a lot of learning, a lot of challenges that we've had to deal with in governance and real world implementation challenges that I would love to share with everyone.
Wonderful. Thank you. Kate? Oh, we can't hear you. Can you guys hear her?
Nope.
No?
You can hear me now?
Yes.
Yeah. Okay. So sorry. So excited to be here with all of you. I always have problems with my headphones. I am Kate Carter, and I am the AI program manager at the City of Tucson. I'm currently pursuing my PhD in artificial intelligence in healthcare, focusing my research on chronic pain management and equity. So outside of my full-time role, which is really interesting because we are those frontline healthcare workers. We're EMS and fighter and police, and they're exploring how AI can be utilized in their services to better serve all of you. I still PRN and treat patients at an inpatient hospital here. And so when I think about how artificial intelligence is used in that setting, it is fascinating with assisted device when you think of amputees and the new mobility features that you can have when you inject AI into a prosthetic. It's so exciting. And I'm excited to be here and learn from all of these amazing women on this panel.
So as you can see why we selected these women. They really know what they are talking about. They've been around and have watched the emergence of Gen AI and LLMs and everything. But so thank you for that. So let's move into our first discussion topic and talk about how each of you how you structure governance within your organization, because every organization does it differently. So how does AI governance differ from traditional AI and data governance programs, or does it? And how are you integrating AI governance into your established organizational processes that already exist? And this is an open discussion. This is just like us having coffee somewhere, so just jump in.
I'll jump in. So because I sit in the IT department, and when you think about technology, you would think that the governance structure would fall within IT. But the reality is governance is every single one of our departments. So police, water, fire, parks and rec, housing development, you name it, we all have to govern responsibly. And what healthcare has taught me is that this can't be abstract. We have to understand that these aren't just AI projects, that these are AI-enabled decisions, and we are all responsible. And we hold those individual departments responsible for the decisions that are made, because we have to point back to somebody. I can't say, oh, it was this technology that failed. At the end of the day, it is that human that should be in the loop, finalizing those decisions or double checking those decisions. And so at the city level, we look at it as all of our responsibility in terms of AI governance.
I can follow that. Our approach is very similar in the sense that it's interdisciplinary, and we've always been doing AI governance in the past, at least 9 years that I've been at City of Hope, because we have to make sure that we are doing right by our patients, right? That we are introducing these technologies, but in a safe and responsible way. We always made sure that we will go to all these different committees for patient care and data and analytics, and making sure that we check the boxes. But more recently, in the past 2, 3 years, we put even more structure around it. So and the reason for that it was actually generative AI because they come with a new set of challenges. These are highly indeterministic models. Like you ask ChatGPT a question once, it says one thing, and you ask 5 seconds later, it can say a completely different thing. And now imagine that you're bringing that into production, into patient care. Like, how do you really deal with that, lack of stability, and how do you make sure that that's not causing any issues? So we had to rethink our governance, and we ended up doing, like, our governance right now has 2 tiers. We have an executive governance committee that meets quarterly, and this is basically all City of Hope EVPs. Like they're at the highest level of the organization. They are charged with setting our AI strategy, prioritization, investment, like really big decisions, and also looking at very high risk use cases. And they have delegated work group members. The work group meets every week, and and we have people from clinicians, researchers, operations, legal, ethics, compliance, data privacy, technical, and I'm probably even missing some, but we have like really good coverage of, to Kate's point, all departments. Everyone has representation, and then we look at each and every use case. We started with an inventory of what are all the AI or ML use cases that we have in our organization. Started going through them one by one, making sure that we look at all of them from all these different perspectives. What is our data sharing and use agreement? Like, how, are we really protecting our patients' data the way that we should be? So right now we are at a very good cadence. We meet every week. We look at each and every use case from all these different perspectives. If something is low or medium risk, the work group is enabled to be able to approve it, to move forward. We communicate the risks and mitigations that we identified as part of the committee. We have a lot of controls that we have developed. But if something is high risk, we bump it up to the executive committee. That's how our governance is set up right now.
And can I just add something really quickly? Just last week, and so this is brand new, Mayor and Council, they motioned to have citizen engagement with our decisions. So like Nassim was saying, we do have an advanced technology committee, and I was just on a call. That's why I was a few minutes late, because we have to form a board of commission of citizens, and so that they can look at the technology that we will be incorporating and provide their feedback, because it will impact all of us. And so I think it's a really new development, and I am very excited about the transparency piece, because it is so important that we are aware of how this technology is being used on us and for us, and so that it's used by us as well. And so I love this piece of transparency and getting citizen buy-in and citizen input. So it's brand new, off the press.
That's fantastic. Mayo Clinic is maybe approaching it from a different perspective, as we all are, because we are a very well-established academic institution. We have a lot of infrastructure, a lot of governance already in place. And so we're trying our best in the last 3 to 5 years or so to leverage that infrastructure where it makes sense and adds value to our AI initiatives. And in some cases, break down some of the barriers that bog the process down. Things move much more quickly in this space and than ever before in healthcare, I think, but at Mayo Clinic in particular, we are physician-led. So there's a physician and administrator who oversee our AI initiatives, and they are empowered at the highest level with the funding and the support of the CEO to drive that, but they don't have direct oversight over all the people involved. It's very much separate verticals, which in a way gives us check and balance to everything that is taking place, because if it doesn't get approved through IRB, nobody gets to bully past that. It has to be appropriate and clear those hurdles. And the challenge is really moving more quickly in an institution that is not used to that AI high-tech pace. And so it's been an interesting experience to find those pinch points and see if we can accelerate the momentum, because things are happening so quickly in this space. At the same time, we have patients who need to be cared for properly, and that is at the crux of everything that we're doing. Is it safe for the patient? Is it appropriate? And we want to have that transparency with patients, staff, everyone involved, so they can have the confidence that whatever we're bringing forward is supplementing the process, not replacing physicians' decision making, nurses' decision making. It's just there to enhance their ability to provide the best care and not consume that role for them. So it's a delicate balance, but very much a balance of our existing structure versus moving quickly.
I also wanted to jump in quickly, Katie, to your point. We also have very mature IT governance structure and IRB and all the things for research, but we decided to have AI governance, at least at the time we started it, to be a standalone, to interface with these governance bodies, but to be a standalone exactly for that point, because we wanted to be able to move quickly, because AI is moving a lot quicker than any other IT technology, right? And we can't wait for like 2-3 months for something to be approved. So we decided that we are standing up this governance body that will interface, will make sure all the InfoSec requirements are, for example, met, and that IRB is aligned and involved when they need to be for a research project. But we decided to do this standalone because we wanted to kind of be able to control that balance of speed with responsible use of AI.
Yeah, and then I'll just tag on that we were caught off guard here at Team Select. We did not have an IRB. We didn't have a very good structure in place. And so for us, we ended up in real-time situations with questions around who is the responsible party. And what are our policies? Where are they stored? How are they socialized? So I think I'd like to just be honest and transparent about coming across that just in the last year or two, and then thinking through maybe what Katie has said is, look, it can't be one person, right? It can't just be IT that says you should use this responsibly. The approach of putting things that I hear from all three of you into buckets. Who is the committee? Who is responsible? Starting from ground zero. And then maybe even being a little bit more honest and saying, since we didn't know what to do, we really leaned on groups like this, looking to seek out what are other people doing. We honestly did use some consulting as well, just to say, like, what haven't we checked for? What rock haven't we turned over? And I think I would just like to echo how fast this is all moving.
So I have a great question from years of experience in governance and people management, because it's really about the people, right? More than the technology. So with all of these stakeholders involved and all of these governance organizations involved, and with technology moving so quickly, how are you handling the challenges that come up that they always come up, right? One team wants to do something, one team doesn't want to do something. How do you handle that in an organization that needs to move quickly and remain secure and ethical?
Yeah, we kind of had to do both, to be completely honest. We had to set hard barriers around what we were going to call our most secure, sensitive information, and then softer guardrails around, and the committee, of course, to approve around the potential and the flexibility. But I'll let the rest of the team members speak on it as well.
Yeah.
Can I clarify the question, Minky? What do you mean with if one team wants to do something and another team doesn't want? Can you give us an example?
So let's say that there's a use case, and one team really wants to move this forward, and they want to. I'm going to give an extreme example. They're going to put ethics to the side and say, yeah, there is a risk, but let's go ahead and do it because it will benefit the patient, and when it comes to healthcare and people's lives, and that is an extreme example. How do you balance the approval process or just getting alignment across all of your stakeholders because that's truly what the governance is, right? Is that people management getting everyone on the same page to say that, yes, this is what we're going to do. Um, how are you guys managing that? Because you all have established organizations, you all have established processes and things like that, policies. How are you managing that? And especially when it's negating another team's or another organization's policy, right? So you have overlapping policies between data and AI and just governance and operations. So how are you guys handling that?
So for us, there is no option to put ethics aside or patient safety aside, or like, so we have non-negotiables, like the patient privacy, patient safety. Those are things that, if the committee decides, if the work group decides that this is high risk, like for us, for example, in our process, anything including patients, PHI, is immediately medium risk. So it cannot even be low risk. It's either medium or high, anything that has anything to do with patient data or with patients. If it's patient facing, if the AI is interacting with the patient, it's immediately high risk. So we do have some like built-in kind of controls, if you will, to say, if something involves patients and patient data, we don't take it lightly. Same with like business sensitive information. So we do have some criteria that says, and if something is deemed as high risk in any of these areas, the work group is going to say, this is high risk for these reasons. We get back to the group that really wants that tool and say, this is high risk. We don't think you should be bringing this to the organization. If they push back, and a lot of times they do because they love the tool, they think it can make their lives easier, then it bumps up to the executive committee to vote on it and make a decision. And for us as the work group members, all we do is we lay out the risks, why we think this is high risk, for the executive committee to make a decision. And we tell them, this tool is we had an example of a tool from a startup company that wanted to have access to our entire clinical, like medical records, to our entire Epic data. They didn't have good insurance or like cybersecurity measures in place. They were not mature enough. And we laid all of that out for and this was a tool that the groups that wanted to use it had very strong feelings about. And it was a great product. Don't get me wrong. I loved the product when I looked at it, but it was very risky. So we said, no, they said yes. And it went to our executive committee to make a decision on. And when they saw the risks, they were like, no way, like we cannot do this. So that's how we kind of approach it. There are things that are really non-negotiable. If there are things that like they are not really putting anything major at risk, like we communicate the risk and we're like, here is the risk, here's the mitigation. You should not be putting anything other than publicly available research data into this tool. You should not be doing ABC. You should be doing, CDF to use this tool in a safe manner. And it's approved contingent on you using it under these guidelines. So that's how kind of we approach it.
And we have similar structure, but another element I'll add to the conversation because it's non-negotiables. They're just things that we will not do. And there are so many great ideas, and probably the same great idea with 50 different flavors already people are thinking about and building. And so we wanted to create a pathway for people to bring ideas forward, and the committee that reviews those ideas will give feedback to those teams and individuals to make sure they understand why it is or is not viable. I think people have great ideas, but they don't realize the cost to build and design that AI model and sustain it over time, because you don't just build it and launch it, you have to maintain it and you have to keep it trued up and validated and functioning in a safe way. And that ongoing support is critical to any idea. So if they don't have the funding in place to do that, naturally that's going to be a barrier to moving forward. But we still harvest those ideas and have dollars set aside to invest in teams that have great ideas, and data scientists and development engineers and software engineers to help them through that build process when they are selected to move forward. So there's an outlet for it, but it's the same. There's non-negotiables. Anything related to PHI, it better cross every T, dot every I, and that's it.
Yeah, and we fall under those same buckets, right? We're federally mandated. Like there's just laws that we have to adhere to. I think it's interesting though when you think about the term risk. I think of it in terms of a patient, and the risk to human society. But somebody might else be thinking about the risk to the bottom line, and they're thinking about that financial element. And so they're like, hey, if we don't implement this, this is the risk to our bottom line. I want to move forward and figure out how we can adopt this solution. And it's a balancing act. And I think what we have on our side is the Arizona Supreme Court hasn't ruled on it yet, or it's just not legal yet. And so we have to use data that's not in production. Or, we can pilot this, but it can't be then in an actual medical record or a criminal record if it was the police, for example. So we are in uncharted territories, and many departments are trying to figure it out. But in a lot of people think of that word risk and they think bottom line. And I understand that, but I always come back to, as a society, what are we willing to risk? And at the end of the day, we have to protect us, because at some point we'll be patients ourselves, right? And so we come first.
Total.
Absolutely.
One more, I'll just add, I totally agree, Kate. And sometimes we will offer the safer option of a retrospective study, right? We're not doing this study real time on real patients. We're looking back at data and validating based on historical information. So there's a level of protection there. PHI is still involved, but we're not using real time people in our clinics. So, sorry, Minky, go
Absolutely.
ahead.
No, no, no. You guys, that was perfect. That was exactly what I wanted to talk about because it is so complicated. And I know China's, there's a lot of excitement about what China is doing with automated doctors, agentic AI doctors and things like that, which you kind of think about where is that information coming from? Where is it going? What's happening with it? And, you're right. They do hallucinate or make errors. And, when the average is 80%, that's 80% of your patients that are healthy, and then another 20% that aren't, right? That are at risk. So with that, when we talk about governance and a fast moving technology, how is governance actually functioning day to day? And so what systems and what tools and processes are you using to manage this governance process to make sure that that the agents are not drifting off, they don't have model drift and they're still staying accurate? How are you guys managing that? Because that's one of the key things in healthcare. It just takes that one time. And I'll give a quick story while you guys are thinking about that. When I was in college, this is the one story that really stuck with me. My database professor said, when you're coding, you need to make sure that you're accurate in what you're doing, because there was an instance where an X-ray machine had delivered the maximum amount of radiation for the maximum amount of time, killing that individual because the programmer had used an int rather than another variable. So when it hit that level, and it was just that one, but that one person died. And so when I think about agents and AI, I think about like, how are we making sure that we don't have that one person?
So I think just model management, you mentioned model drifts and data shifts. I don't think that is like exclusive to AI agents or generative AI or LLMs or even AI. This is like for every machine learning model, good old decision trees, like you have to have those things in place. So one of the things that we do as part of our governance process is model management and testing plan based on the use case. We have a fairly large team of AI experts, like PhD level AI scientists. So we are fortunate in that way. So we can look at whether it's an internally developed tool or external tool, we can we can come up with the requirements for testing, for retraining, like how often this model should be retrained. If there is bias testing that is needed, how often should it be repeated? After go live, what are the things that you should be looking at, like in terms of metrics? It could be like downstream clinical metrics, or it could be like statistical metrics in terms of these models are still healthy, they're doing what they're supposed to be doing. If the underlying data is shifting, that whole like machine learning ops or ML ops, as we call it, it's a whole world. Like if you're doing AI development in-house, you definitely should have that in place. If you're only taking in third-party tools, you should still have some level of that. You should make sure that you are not only governing to the point of implementation, but also after, and making sure that these tools are staying on track. So that's that. And then when it comes to AI agents, I just want to mention that I don't think there are any AI agents, I hope not, in any healthcare system running loose on their own doing stuff. I think that there's always a human in the loop, and there should always be a human in the loop. We have a lot of, like, we're probably one of the most advanced in terms of implementing large language models for different operational research and patient care applications at scale system level. But we always have a human in the loop. These are not autonomous agents. There is always a very specific workflow that we are trying to impact. And AI can make us 10 times more productive and and be very useful, but no AI agents for us that we have to like govern their behavior, or even when we use AI agents for coding, we are very strict about what folders they can access in your computer. It should be only your project folder. It should not be. So I think that AI agent governance is a really big topic. I think it's almost untouched. And so we take it, we are very conservative when it comes to AI agents and their autonomy. We do not let them to be autonomous, at least at City of Hope at this point.
And we
Same.
don't, yeah,
Yeah.
we don't have that amazing team that you have and that availability to build internally. Like I wish that we did. And so I've spent a lot of time with procurement and legal trying to strengthen our contracts because these tools and systems aren't static. And how do you bake that into your contract before you procure is something that needs to be considered. And discussed within your staff because again you're interacting with a solution today that might function completely different 2 months from now, and that new functionality might change the security level and risk, and so just being mindful of that as you, whether you're building internally or not, the same stays true, that we have to be extremely responsible and then govern in that mind that these solutions aren't static, they are dynamic and they constantly change and evolve. And then we have to evolve with them within our practices.
I mean, we've noticed as Mayo has just started down this path, we're not as far along as City of Hope. We have been developing things in-house, and we've brought in resources that understand AI, large language models, how to build and manage them. And then we have experienced with handing that off to our IT partners in the different parts of our practice that there's a knowledge gap in some cases, and therefore we've now incorporated a lot of upskilling and hiring more resources for our IT colleagues so they are comfortable maintaining the tool and we're very careful not to pass it off to ongoing support until that's in place. And so that way we are ensuring that all the testing and work that we did up front to build, design, create is continued after the fact, after it's deployed. So it's important to have the structure in place, and we're learning now, what does that look like? How do we make sure those skills are there? And keeping the other piece that we have too, there's nothing that is running amok. Nothing runs amok. Everything is leashed and well harnessed. And with some of the tools that we've developed in-house and launched, they all have they are all cited, right? So if you're getting a summary of the patient medical record, large language model is putting together a summary for you. It is not interpreting the data or telling you what to do with the data, it's summarizing it, and then it cites all of its sources. So you, as the physician, can then drill down and see the original source document and confirm. And that is the intent behind all of this, is that you're the decision maker, the human in the loop, the physician. You are using this tool to accelerate your work, not replace it. And at that level, so far, we've seen a high adoption rate because they see the value and they are not, replacing their own decision making and their own judgment. So it's an interesting process.
And I love that. I'm sorry, Meg, go ahead.
Oh no, I was really just mirroring a couple of comments that I heard that I just want to say has been really critical. One is Katie, you said we're not letting it run amok. And I think what you meant was we're very intentional with what we have allowed this to do. And I do think that I've seen in other space, not healthcare, where it could have the potential to run amok. And so I hope that we don't come upon that soon, but I do think it's could be coming. And then the other part was transparency. We early on experienced some users that didn't quite understand what their part versus our part was, what the user's part in the decision making, even though we built it with that intention. And so we have socialized that throughout our organization. And I think we continue to have an uphill battle, like really actually trying to understand. I just want to joke, Katie, you said on a different call something about, if we can explain how to turn the TV on, and if we can explain it in their words, like we're just going to have a better outcome. But we do find that socializing this in a language that everyone understands has been instrumental thus far.
I also wanted to add, that's a great point, but I also wanted to add, no matter which level of maturity an organization is in, or the resources that you have available to you, whether you're building internally or externally, I think that everyone should have benchmarks and gold standard data sets, even if it's for a very simple workflow, you're using ChatGPT to automate it. And just, that's something that is very, I guess, common these days. But like ChatGPT is changing under the hood every day. Like you may have noticed it in your personal use, like it's not the same thing, it's changing under the hood. So it's very important, even if it's like a manual process of you like testing I don't know, for your workflow, like 100 times with something that like, okay, when I implemented this tool, I ran these 100 questions, I got these answers, and it was like 90% accurate. You should be doing the same, even if it takes a lot of time and effort, even if it's manual, every now and then, because these models, a lot of third-party tools are sitting on top of these foundation models. They're either using OpenAI or Google or Anthropic, and we know that they are coming out with new versions every day. So I think it's very important to, at the application level for every workflow, to know exactly what you're anticipating this tool to be doing, and check every months, every 3 months, every quarter, whatever the cadence should be for that use case, to make sure that they're still doing the same thing. I don't want to be like fear mongering or anything like that. Usually these tools get better. Usually you won't see like a huge drop in performance, but you cannot just blindly trust that OpenAI is always getting better. We have seen in our applications that we switch to a newer model, and then we have very mature evaluation pipelines, and we see that our downstream tasks, sometimes the performance gets worse. So we switch back to the old models. So I think that everyone, given the resources that they have, should have some level of ongoing testing and validation.
Totally agree. And I think it's not only the tool, it's the science. The science behind it is changing,
Yep.
and it will accelerate and change more quickly in the space of these new tools. So we should always just be refreshing. It's a continuous improvement should be the norm. We should always be auditing, reviewing, testing.
And that was exactly what I was thinking about, is that how do you at scale test it? And then let's move that question to the next one, where you are at scale, you've got a model deployed, and Mayo has global locations. A City of Hope also has a variety of different locations. And when we start looking at different regions and cultures, how do we look at contextual fairness and equity? Because when your model is trained on a certain data set, how do you ensure that it's ethical across the board with all of the diversity, cultures and different ways of doing things?
I will say I've been very impressed, and I'm not just saying this because I work at Mayo. I've been very impressed with the platform, Mayo Clinic platform, because they have built a consortium with a number of health organizations to pull the data from their patient populations. And this is deep data. It is not, the what's been billed on the end of the process. It's medical record data that has been de-identified and pooled in a secure fashion. So we have millions of patients' data, longitudinal information available in this consortium of this platform tool so that we all can have access to data from across the spectrum, because Mayo Clinic sits in certain parts of the country with certain patient population. Is it a representation of everyone? That's impossible. It would never meet that. So if we all pool our resources together, which is what they're trying to do and have launched, they have this huge set of deep, de-identified, longitudinal data available for practices to use. And I think uh, we live in a country where we don't have a unified healthcare system where it's all in one place. And so it's naturally fragmented, and it's going to be up to individual organizations to work together, I think, to really build a tool that is available to everyone. So we minimize bias, minimize the impact that um, that can have on the patient population.
That's
That's
right.
amazing. That's
Sorry.
amazing, actually. I'm so glad to hear that. Nassim, go ahead. I'm so sorry.
No, I just wanted to say that applies to AI development very well, right, Katie? So that's great. Like if you're developing an AI tool, you want to make sure that your data that you're training on is representative of the society that you're treating, if you're in patient care, for example. And that's, there are steps you can take, like using Mayo platform, access to more data consortiums, or just making sure that the data you're training on is representative of the tool being used in the real world. So that's one aspect. That's a very important aspect. But a lot of times we are just using, let's say, I don't know, Epic is coming out with these generative AI features. There are third-party tools that we don't have a lot of visibility on how they've been trained. And that's for us, then we ask a lot of questions about, and fairness and bias is not always applicable, but that is like something like an intuitive common sense or criteria you apply to say, is this tool, does bias even apply to it? If the answer is yes, then we ask the vendor. We have a vendor form we send out to them. They have to reply to us if they want us to like consider the tool. There is a lot of questions in the AI vendor form that asks about how this model was trained, what bias testing was done, what the results were, what the performance were. So we get the results, but we also do our own because we realize that patient populations are different. So we make sure that if there is a risk for fairness and bias, that we test on our own patient population, that we make sure, like for example, if it's a voice agent that is interacting with patients, I always test with my accent to see if it understands my accent. Or different accents from like the different patient populations that we see. So I think testing and validation in your own patient population for the group that is going to be actually impacted by this tool, whether it's patients or staff, is key for internally or externally developed tools, but especially externally developed tools when you don't have a lot of visibility into the training process.
And I think that's a great use case for keeping the human in the loop and discernment, right? That's ideal because I think we had talked about it earlier. And so off that same topic, how is it that you have, let's say that somebody's going into this entire governance and they're looking to adopt AI and into their organization. What what did you find that you hadn't thought about and that came up as one of those things that just came out of left field? Was there anything? I know that all of you are very, very conscientious and intentional in understanding exactly what the tools are doing. But was there any point that something came out of the blue and that surprised you? And you could say no.
What day of the week would you like for me to today? One thing that I thought was interesting that we came across, we were looking at a particular drug that has serious side effects and may not work on the patient population. And so they usually have to test on that drug for 6 months or so before they know whether it's going to address their health issue. It's a rheumatologic drug. And we developed an AI model that would, with a high level of accuracy, predict whether that drug was going to work for the patient so they could bypass that step and go to the next option on the list and not have all these awful side effects and not have to spend 6 months wondering if the medication is going to work. So, fantastic tool. However, the insurance companies and CMS require that you go through that medication first before they will cover the next option. So these learnings that we've come across along the way, like, oh, so now we're going to have to look at the insurance or the healthcare system externally to encourage, guide, and help them adapt to a world where this is actually better care for the patient to not have to go through 6 months of a trial and error process and allow us to skip and cover the next part of that treatment plan. So there's always some kernel out there that we stumble across and put it in our back pocket because it's interesting what you find along the way.
I think for me, um, I started out naively in my role and then soon realized that I have to treat AI governance and ethics like infectious control, like you do in a hospital, and that we need a true like triage plan for when things go wrong. Like, what is our contingency plan? Not just for easy hallucinations that are like you can identify them, but when something that goes wrong that causes ultimately risk and harm to society. What is our plan? And I am still working on through those steps and stages with cybersecurity and with our GRC team. Because I want to think that far ahead. Nothing has gone wrong. Like nothing's gone wrong, but I want to plan in the event that it does. And so a true AI governance, infectious control type of planning and triage planning and staging is really important within this line of work.
Absolutely. Perfect. Perfect. So let's shift away from policy and over to people and how governance is lived across all of your teams. And I think we're coming back to our initial point. So governance only works when people believe in it. And how is your organization building that trust and collaboration and AI literacy amongst your clinicians, researchers, and operational teams to ensure that staff feel confident? And you've all described how you've created these amazing organizations. If you were talking to an organization that doesn't have that trust yet, that is just going into it, how do you ensure that the staff actually feels confident using AI responsibly? And you'll always have the naysayers that don't want it to work. So how do you get that adoption and collaboration to happen? And again, this is for those organizations. You have a streamlined operation. How do you get, if you were to give an advice to someone, what would you tell them to get the organization on board?
I'll just say, I don't think we're there yet. I think it's every day, bit by bit, we need to be transparent, educate, bring people along. My role, because I'm not a data person, I'm not an IT person, my role is really to be an ambassador to these tools, to put it in a language that my peers can understand and help them to feel secure, safe, willing to try, put themselves out there. I do think we have a really good adoption rate, but we still see a lot of fear and anxiety from staff because it could be job security as an anxiety, which is very much a real concern, I think. And then it's the fear of the unknown and what is the should I put the foil hat on now or should I, what is this going to do to our world? So it really is long-term education, getting in front of staff, helping them understand just the basics, and reassurance that all the safeguards are in place and that no one is taking this lightly. It's not just for fun, it's exciting and it's going to revolutionize how we deliver care and it will be done responsibly and safely. So
Yeah, I think what Katie's trying to say too, like in another aspect, is none of this should be in a black box. It should all be really open because users know that this is new too to us. So there's no reason for us to maybe even convey that we have all of the answers, but engage them throughout the entire process. This has changed. Do you know these facts? Socialize. I think the one thing that I felt was pivotal was, and maybe even what Katie's role is including an ambassador. For us, it was a team of nurses really early on in all of our development and having them actually socialize with the end users so that they could talk about making sure there's no secrets, there's no magic, there's just the data that they're actually putting into this environment and what we're trying to do so hard to help them with. So I thought those were very helpful things, and the job's not over.
The job is not over for anyone, I don't think. And I want to piggyback on what you said. I think it's very important to, especially for AI development, to develop with the clinicians or end users rather than for them. So that really helps with the education piece because we meet every week for like a year or more when we're developing something with the end users, and we try to we co-develop something with them. And when someone feels ownership, they feel like it's theirs, they feel like we're doing this for them and with them, it's it's a much higher chance for them to adopt it when it's done. So that's one thing. And even give us a pass when it's not perfect, like because they have been through, like we've done our best week after week to improve it, and things will never be perfect, but when they know, they are kinder to us. So that's one thing. The other thing is I cannot overstate the value of education, especially when it comes to adherence to the AI policies. And, it's one thing when you say, if you don't do this, you'll get fired. It's another thing when you actually educate people on why you're asking them to not use PHI and ChatGPT. Why is it that you're telling them this is not safe? So really getting people up to speed with some of what's going on under the hood with these tools that they love so much, and just making sure that they understand the risks as well as the capabilities of these tools is very important. And when it comes to job security and things like that, I think the best we can do is to be really open and honest, because this will happen. Regardless of whether or not we want it, this will happen. AI will take away jobs, and I think the best we can do is to get ahead of it. How can we upskill those jobs that are at risk? We work very closely, like with our HR department, for example. And I mean, we should make sure, and HR is part of our AI governance, to make sure that if there is a tool that is being introduced that may impact people's jobs, that we have a plan for it. So I think that being rather than avoiding the question or saying, no, AI won't take away jobs, we're just doing this to help you, we're just doing this to make us better. I think that we should acknowledge that there is a risk for all of us. There's a risk for me, and I should be cognizant of that and think about what can I do to get ahead of it. I think that is our approach, to be transparent, honest, and also all of us to help each other to see what we can do to prepare for what's coming.
And our approach here has been, I've been extremely diligent about driving a community and trying to create a community. And so what that looks like in the real world is just a Teams thread. And when somebody asks to join what I call the AI Club, I welcome them with an email, and it has a badge that says "Welcome to the AI Club," so that you feel like it's a real community that you belong to. And within this Teams thread, people are sharing those news articles of the 30,000 layoff here or the 10,000 layoff here, because we have to have those conversations. They're facing all of us. But then they're also sharing, hey, this mega prompt helped me do X, Y, and Z. And because there's so many different departments within this Teams thread, we're allowed to share that knowledge. And that's been a real benefit and resource. But it's created a safe space. So in addition to that, I have asked our CIO to have monthly or quarterly, we've done 2 so far, lunch and learns, where it's just an open, hey, just come and let's chat about what's happening right now, whether that be at the federal level, state level, or local level, or a specific industry or vertical, or from a conference, so that we're sharing that knowledge with each other. Because I think it's important when you look at whether it's our health insurance decisions being automated and denied, or this new pilot that Medicaid or Medicare is going to roll out that might deny us our care, that we are talking about it as a community, because it might not impact you directly, but it could impact your neighbor. And you could share that knowledge that you've gained on how to proactively rebut that denial or ask questions if AI was made that decision, was a human also in the loop. So it gives you some sense of power, because this technology is controlling so many elements of our lives. And I think it's only natural for us to be a little bit fearful and curious. And if you could create that safe space, it gives a platform and a voice to people to buy into how you want to adopt at your organization.
Yeah, that's wonderful. And I think that, majority of it, if it takes 80% of the work that's process driven and removes that, it allows employees to really focus on the 20%. That's very, very important. And one of I think people might get tired of the story, but I love this story. One of the companies here in Phoenix, for adoption and engagement, they've started creating a Shark Tank type of atmosphere where the employees who know the problems are leveraging AI to pitch to their leaders and executive board to get funding for these solutions. And it's a beautiful approach because you are engaging your employees, it's workforce development, it's cultural adoption, and it's actually it's fixing a problem that exists. And so that cultural change, it's much easier to trust your coworker than to trust a consultant or some outside vendor coming in, because you're 50% of the way there with the trust. And that's what it all comes down to: is how do you engage your employees and make sure that there is, we do have to say that yes, there is a risk, but how do you stay ahead of that? And if you're building a culture of curiosity and discernment, you will always be ahead of AI. So I want to thank all of you for your great insights. Before I go to questions, is there any one one thing that you would actually say to people that you've learned as like a bit of advice when it comes to AI? And I know it's just changing every day. But what is that one piece of advice that you could give them to have like a great operational governance program in place? You can think about that.
I can start. Yeah, I can start. Anyways, I'm only going to pass forward the advice that was given to me. So I kind of feel like a cheat a little bit, but it was, my mentor had said, don't try to boil the ocean, just try to boil 1 cup of water. And where this applied in governance was, we stayed true to just one topic, and that led to understanding a very clear purpose, very clear role clarity, and then layering on the policies, the committee by just staying really focused. So our approach was kind of start small, and that's what was successful for us.
I think that is great advice, and I will add to that, get as much help as you can, include as many people as you can, because it's a big responsibility to be on one person or one group's shoulder to like hold down the lines for AI safety and responsibility. So I think it's very important for it to be multidisciplinary, to bring in different perspectives and different expertise. That has helped us a lot.
I echo what you two just said. It's the same for us. It's scope creep. Keep a very clear focus on what you want to work on and small bites. How do you eat the elephant? One little bite at a time, and know your experts. Know who you can call who will help drive you in the right direction.
Oh, all of it's so good. I think it would be to maybe clearly define for your organization what responsible AI means. Um, for you and your organization or your team, and then test everything against that sentence. Like to me, AI responsibility means insert and then test against it and keep testing against it to keep hold yourself accountable. Because as soon as you start to let things fall through the cracks, you've already lost the battle. And so we have to treat this new technology, it's not new, but treat this technology with caution and with care within this line of work. And so, yeah, define what responsible AI means.
Thank you. Yeah. So basically, just get started, but start small and manageable, but just get started. Okay, so let's go to our first question. Could you speak about the private public IP and commercial impacts? So how do companies protect their IP, their models and tools as they're deployed across the healthcare industry? So medical and diagnostic is a new use case for this organization. And they're using their algorithms in a new direction in this new world of LLMs and ChatGPTs.
Minky, it's Steve. I just want to make sure you saw that there are lots of questions in the chat that we will want to try and get to. And I'm going to have to leave for another event. So if you could close out the event, I would greatly appreciate it.
Yeah, I will. Thank you. And yes, that was actually Thomas's question. So
Excellent. Thank you.
thank you.
Thank you all.
I can speak to some of what we've done in this space. I mean, we have put patents on our algorithms and things that we've developed in-house if we intend to take it externally. So to add that little protection and of course the contracting relationship that we would establish in order for others to use that IP. What I think is going to be interesting in the coming years is everyone is developing things right now and bringing things to market. And so it's really incumbent upon anyone purchasing or using a tool that they investigate thoroughly and ensure that they know enough about it to use it safely. I'm less concerned about protecting IP because I think there's a barrier to entry for folks. I mean, the amount of processing power that we had to purchase in order to run our data through the algorithms we built was significant. So I don't think everybody's going to be a creator and a developer. I just don't think that's feasible. So it's more so on the use. How are they going to use that information? How are they and how are, what needs to be protected and monetized versus what needs to be democratized so everyone has access to the information and the tools. But patents, contracts, all the usual attorney stuff.
Yeah, and so I think that we don't talk about that one point that you made, the processing power. I don't think that we really bring that to light. So how did that surprise you with the amount of processing power you actually needed? Was it like 10x or what you estimated or?
Significant. When you think about the way we used to have, and Nassim could probably talk circles around me in this space, but the processors we had historically were very linear in how they functioned. So we had to redesign those processors, and it is incredibly expensive. And when we were first going down this path, the wait time for them to be produced off of the factory line was months and months. So that will change in the future. Obviously, things will become more accelerated, but I don't know that just anyone could stand something like that up easily. And maybe Nassim, Kate, if
Yeah.
you and Meg, if you have.
I agree. I think it's like, again, I think we should differentiate between AI development training and then inference, which is using it. AI development, if you're going to be developing a large language model from scratch, if you're going to be using trillions of tokens to train an AI model, that takes a ton of compute. That's something that probably most provider organizations won't be able to afford or won't be even up for it. We did something like that at City of Hope. We built the first oncology specific large language model framework. Again, because we had the compute power, we had the team, and we had the desire to do it. But even if you want to just implement things that sit on top of, like, for example, OpenAI endpoints or Google endpoints or Gemini endpoints, it still has, you don't need a lot of compute or processing power, but you will have to pay for each one call that you make, like each one question that you ask from these foundation models that are under the hood. So I think what may surprise a lot of people is when you go from pilot to production at scale, these numbers can add up. You may do a pilot for $100 that everyone loves and it works very well, and then you're like, okay, I want this for all my patients, and then it's suddenly $10 million per year. So that's, that kind of how things add up. I think that's something that may surprise some people, especially if you're doing this for the first time. So even if you're not developing models, you're just deploying them, the compute cost is something to be mindful of.
Yeah, exactly. Exactly. Thank you for that, because I think that is one thing that we all just skip over, right? And it's a very important piece of it. So we have a question for Meg. What were some of the most important resources when learning, and what were some of the considerations specific to your organization that you considered when putting your structure and governance together?
Oh, well, I have to reiterate that it was a tiny bit on the fly. So just to be honest, we actually we did two things. We looked to the community that was around us. We are a part of, a portfolio group that had quite a bit of resources and we're doing other implementations. So we, of course, looked around us, just like a group like this is, which I love that we're having these sessions because, Minky, I think this is the type of community to lean on. In this situation, we also did some third-party consultations because we just really didn't know everything. And finally, when we were putting our governance board together, I think everyone has echoed this. We were very inclusive. So we were looking to make sure that all stakeholders were a part of our governance team and had understanding. Yeah, and I could end up just floundering with the conversation. Is there more question around that, or I could even get more specific?
I think that's from someone with the initials AM. I'm not
Oh,
sure who
okay.
that is. So if they
That's Alicia.
want,
It's just me,
oh,
Minky.
hi, Alicia. I thought that was
Hi.
you, but I didn't want to assume. So yeah, was there more to that question that you wanted to know?
No, it just, I always am interested in how culture plays into not just what type of organization, but how culture and just kind of what you have on hand forms a structure and governance also. So
Yeah. Yeah, I think Katie alluded to this a little earlier and said typically we think of some of technology product as technology governance. And so we did stumble upon that barrier. And so we really wanted to make sure that the IT department wasn't making the rules in our governance and our platform. So again, when when we looked around at other healthcare providers and other industries that were doing well in structuring their policies, we didn't want to reinvent the wheel, but the underlining theme was inclusivity, having the conversation. I think Nassim talked about a cadence, and that was one thing that it wasn't a one conversation and then great, the policy's in place and move on, but definitely evolving and changing. Katie's mentioned that a couple of times. We've actually gone back and forth, and I don't know if this is an interesting concept to anyone else, but our policies were originally very narrow, very spelled out. And we actually quickly realized for our user group that we needed to back up a little bit and be a lot more educational, not vague, but directional. So those are the types of changes we've had to make, and our different stakeholders within our committee is really what adds that value for our group.
That is awesome. Oh, I'm sorry. Go ahead, Katie.
No, and I actually think I think healthcare is a naturally good place for AI because there's such a focus on taking care of patients and making sure the patients are first. So we have our digital Hippocratic oath that we've pulled together for our staff. It just meshes well. This is another intervention that you're using with your patient population. You would be no less risky in the patient space with these other tools that you use. AI should be treated with that same level of respect. And we need to continue to have that non-maleficent approach to how we utilize this information and the power that it brings. So I think it marries well with the caregiver, physician, nurse, provider concept and approach and culture in general. And if we tie everything back to that, putting the patient first and at the center of whatever we're doing, or the community health at the center of whatever we're doing, it makes it very easy to see what the right next step is because the patient's going to direct that for us, or the community is going to, whoever we're serving is going to take the lead in how we move forward.
And just
Wonderful.
quickly, I wanted to add that I shared in the chat the NIST AI risk management framework, which is what we utilize. And there's an entire playbook and roadmap that you can follow to look at one, trustworthiness, but development and deployment and all of those the things that you should be considering.
Perfect. Perfect. So going into the one M word that we never want to use in healthcare is malpractice, right? So what might the ramifications be for malpractice claims in the future? With will the liability potential extend beyond the practitioner to the governance committees as well? And do the patients have to be informed that their care was actually based on AI trained tools or models when they were used in their care? And that becomes, because Katie, you had talked about not knowing that you have to take insurance claim or insurance coverage into account. But your AI model had said, this is the next best step, but the insurance stepped in. So now you have this kind of offset decision. How would that work?
So great question. Great question. And I just had a great answer and it slipped right out of my mind at the end of the day. No, I think we have to treat this like we do anything else, any new intervention that's brought to bear, it's brought to the market. We need to protect our staff. We need to make sure we're utilizing it in the right spaces and not deploying something before we feel confident in doing so. Like anything, malpractice insurance has to be there. We have to have the insurance in place. We have to have those protections in place. And how we've tried to approach this is, there are a few laws out there, but not many governing this space. We do not want to be the ones at Mayo to create the case law that shapes what it's supposed to be. We want to stay away from that line as far as possible. And so very, very thoughtful and intentional and what are we using, how we're using it, informed consent is absolutely necessary. So we've never utilized these tools with patients without their full knowledge. And a lot of what we have is not even used on patients at this stage. It's really inwardly administrative burdens. How do we alleviate that? And where we've utilized tools, it's been very transparent. Informed consent has to be a part of this process, period.
I completely agree with Katie and don't ever want to see the day where we're not telling our users and end community what it is that we're doing. I want to echo again, we've designed this with such intention for the good. The last thing we want to do is then not allow the users to understand what it was that we were trying to do with it. So informed consent every day and all the time. But I think this conversation will become more and more interesting. Naseem has said a couple of times, we're really clear that we are not making the decision. And just to say about malpractice is around a provider who's making decisions ultimately and care providers who are making decisions. We shouldn't be making any decisions. We're really just trying to help bring all of the information or redundancies to a minimum. And I don't want to be on the news with the first case example either.
So for us, all AI is in the patient care space is decision support. We make it very clear. This is a tool that helps the clinician make decisions better, faster, more efficiently. This is the AI is not making decisions on its own. And we have disclaimers all over the user interface everywhere that this is a decision support tool. This is an AI tool. This may make a mistake. The other thing that we have in place is that we have references. We always have references when it comes to anything that comes out of a generative AI model. We always, every sentence can be traced back to, the source document, so people can quickly verify. And we've made it very easy, user-friendly for them to be able to verify quickly, and we encourage them to do so. If they don't do it, it's on them. So we make that very clear, and that's part of where education comes in as part of our governance process. When we approve these tools, we require for certain education of end users to make sure that they understand the limitations of these tools and that they may make mistakes and what they should be doing to get ahead of that. And then at the end of the day, it's only a decision support tool, not making decisions on its own.
And this is just an evolving space and it's going to continue to evolve. I only imagine that there'll be no fault clauses baked into malpractice insurance. And I think that like the legal framework, what might center around how autonomous the system is. So did it make decisions just completely on its own and there wasn't that human in the loop, then maybe a patient has a claim. But this is just such a ever evolving space that as patients, we need to stay aware of. And then as providers, we also need to stay aware of. It's quite fascinating, to be honest with you.
Fascinating.
I love how this comes full circle to what we actually started the conversation with this afternoon about discernment and keeping the human in the loop and having that human make that decision to say, this is how we're going to proceed, rather than just following what the tools are telling you, right? It's just always support tools. And I have to thank Paul Sim. This is probably the best question I have ever seen to end out a session. Can the presenters please each share a success story that resulted from the implementation of an AI application in their organization?
I can.
And I love that. Mm-hmm. Go ahead, Missy.
So we recently, as I mentioned, we deployed Hope LLM, which is our oncology-specific large language model framework across our system. I wake up every day to emails from doctors that tell me, and one of the things it does is it helps doctors prep for their first visit with a new patient. So going through like thousands of PDF documents and providing a concise summary. So I wake up to emails that say, thanks to you, I can get some sleep tonight because what would have taken me 5 hours to prepare for my next day visit now takes 5 minutes. So that's something that gets me going and makes my day every day. The other thing is we are using Hope LLM also for clinical trial matching, finding trials for patients who otherwise would have had no options. Clinical trial matching is very manually intensive and it's impossible to do it for all patients or trials at all times. But now we have automated that end to end using these generative AI tools. So very excited for it to be, it is being used. We get a ton of engagement and a lot of great feedback from our clinicians and patients.
I'll share a couple of examples happening at Mayo right now. We have our Hope Sphere initiative. It's a virtual reality tool, and its initial use was in our proton beam facility. In that facility, the adolescent child is going into the gantry by themselves for this proton therapy. And if you've ever seen it, they have a metal mask that is fitted to their head, and they get bolted to the table for this therapy, this treatment for their brain cancer, the brain tumor. Very, very unsettling experience. But with this virtual reality tool, the parent can join them in the gantry in a virtual space and be there with the child, see what they're seeing, be there for auditorily, visually with the child. And we're expanding that now to our palliative medicine space. So imagine you have a parent or a loved one on the other side of the world that is not doing well. Now they can put on the virtual reality goggles. Hopefully they'll be much smaller than what we have today in the future, but the goggles, we have haptic gloves where they can feel the loved one holding their hand, virtual in that space with the patient, or we can convert their hospital bed, hospital room to their home and convert the space to look like their home. So there's so many ways that these tools could be applied that it's just like, what if during COVID we had had this tool, right? All those patients who couldn't have family with them. So there's some exciting things happening in addition to the medical record getting summarized, the thousands of PDF pages getting summarized so that the data accuracy that we expect out of our physicians for them to sift through thousands of pages when digital tools can cite every reference to that particular medication for them is just, we have high expectations. And so those tools are really revolutionizing how quickly we're able to provide the right care to the right patient every day. Plus these other exciting things that I just geek out on. It's awesome.
Those examples made my heart so happy. Here, Paul, it's not a success yet, but I am willing it into existence that it will be successful. We will soon be enabling a feature for our EMS workers or firefighters when they're out assisting patients in their time of need after a 911 call. To be able to dictate their documentation in seconds versus however long it would typically take them. And so what often gets missed is those critical key medical elements, how the person was found and the positioning and what's really going on in that scenario for that handoff to the emergency room. And so when that emergency room then has the patient, if you're missing some of those key critical things, it might completely change your course of treatment just based off minor verbiage that was missed in that note. And so what I am hoping is that this allows for more complete documentation for that handoff for continued care. It also allows our EMS workers to capture images of medicine bottles and driver's license, and then it will automatically incorporate it to the correct fields within the software. And so fingers crossed, it is successful, and we just see overall a better continuation of care.
Oh
So
my
amazing.
gosh.
I'll throw in our tool that we're launching right now and try to be quick because it looks like we're low on time. But we have just launched what we call CareSite AI, and what we're doing is trying to keep medically fragile children out of the hospital when preventable. And so we find, We do our services in the home setting, so we don't have 24-hour yet monitoring of these patients. What we've done is taken their very personal information and monitored it across their baseline and across 90 days. And we have found that we are predictive within 24 hours of an acute illness. And on a clean data set, we are predictive 100% of the time. And so after launching this tool, we have already prevented a dozen of hospitalizations, and hopefully we'll just continue to help our nurses, our providers, and our patients just catch the things that that we can. So pretty exciting.
What amazing stories, truly amazing stories. And I think that a lot of times we get stuck on the operational side of it without understanding the impact side of it. And those stories are just perfect because those are perfect use cases. And how do we make that happen? I want to thank all four of you. This was an amazing session. Thank you. And for all the attendees, thank you for coming. And this will actually be available tomorrow in our Google folder for you to listen to again. And thank you again.
Thanks,
Thank you for
everyone.
having us.
Thank you so much. Be safe.
Take care. Bye-bye.